Dr. Butler, who spoke briefly at the introduction session, is my boss, and he's a great boss. We joke that we sent him all the cases that we can't figure out. I won't point fingers, but there's people in this room that I couldn't figure out, so they're seeing Dr. Butler. It's good to be here. I appreciate good colleagues. A lot of what I have done with concussion has been due to others. I was involved in concussion research when I was at the Air Force Academy for several years, and excited to share something about which I have a lot of passion, and something that's challenging to understand because the evidence changes, and the way we took care of concussions 20 years ago is very different than the way we take care of it today. Even 5 years ago, it's changed a great deal. I do want to thank my daughter, Margaret Ann, who's a student here at BYU, who helped me make these slides a little spiffier than they would have been without me, with me on my own. So we're going to talk about recognizing concussion, both as student athletes, as parents, as athletics administrators, how we respond to those, how we can optimize recovery, and just some basics about returning to sport after concussion. So here's our objectives, and just a little more granular than our initial overview slide, but even concussion diagnosis is tricky. We'll talk a little bit about that. We're going to talk about exercise in treatment, which is a change from even 5 years ago. We'll talk over a few other components of treatment. We'll talk about some of the challenges when a student athlete or a youth athlete is trying to recover from concussion. We'll talk about a few things that have been shown to prevent concussion and a few things that can optimize recovery. So exercise is key for treatment. We'll talk a little bit about the timing for that, what type of exercise and when do we start exercise. One of the challenges in concussion care is mental health symptoms, and this can apply to someone who has a diagnosis of depression and then has concussion. It may be that an athlete is concussed without any prior history of anxiety or depression, but then has that as a significant component of their recovery. As far as, if there's 3 things you remember after today, it's that exercise is key, a key part of treatment, being aware of the challenge mental health symptoms can pose, and then just the importance of early intervention for concussion injury, and then making sure the student athlete, the youth athlete understands how we get better from concussion. So I like bringing this up. We talk about signs and symptoms in medicine, and signs are what an observer observes. So that could be a teammate looks off balance as they walk off the field. Symptoms are what an individual tells us. Boy, I got punked on that hit. I don't feel that great. So we'll talk a bit about that as we go forward with these slides. But before we even talk about concussion diagnosis, we talk about prevention, and often we forget about prevention. What can we do for prevention? Some specific interventions have been shown to help with concussion recovery, concussion prevention. And I list them here: mouth guards in youth hockey, pregame warm-up in youth rugby, limiting contact in football, which is taken more from collegiate data, but some limited high school data. Why just these 3 things? These seem kind of like random specific things. It's because somebody's done the research to prove the point. There's other things that we do now that probably prevent or decrease risk of concussion. There's things that we could add that are specific, and then some generalities. It's interesting with football, again, college data more than youth data, but several years ago, the NCAA decided to eliminate 2-a-day practices to try and reduce concussion injury. That was the big reason for that reduction. Interestingly, concussions actually went up because coaches were trying to get everything they could out of the allotted practices, and we saw more concussions. So they then changed the rules to say we're only going to allow a certain number of contact practices in the preseason, and in that case, concussion injury went down. Other prevention potential specific changes could include things like some things are kind of outside the box, but could we have a cumulative penalty system in certain team sports, where if there's a team that has a lot of repeat offenders or much higher volume of injury than, causing injury than other teams, is there some kind of cumulative injury? With wrestling, could there be, penalties for certain holds or maneuvers that put somebody at high risk of concussion. That doesn't exist now, but those are things that may be researched and potentially implemented. The generalities or education as we're doing right now, getting community buy-in on proper care for concussion and awareness for concussion so that we're having a unified voice for rule changes that may help reduce risk. And I use football again as an example that often standing on the sideline of a high school or college football game, I'll hear a comment to the effect of tear his head off, or let's go kill that guy. And the idea is, no, I'm going to play hard until the whistle blows, but everybody's respecting the head and just creating that culture. All right. So diagnosis, I bring this up not because we expect you to be experts on diagnosis, but even for physicians, it's challenging. And the definition for years has been somewhat vague and nuanced, but it's an impact to the head and then neurologic alteration and persisting symptoms. But, we've wanted something more granular. With brain injury, we used to call it a brain bruise. It's really more of a change at the cellular level in the brain, where there's change in the permeability of cell membranes, there's a change in neurotransmitters, there's a change in the vasculature within the brain. There's a new criteria-based way to diagnose concussions, which I really appreciate, and it just is kind of a cookbook way to do this, but there's an impact to the head, one or more signs, and this can be loss of consciousness, altered mental status, amnesia, posturing. We'll talk more about posturing, what that means. 2 or more symptoms. This can be, any classic symptoms such as headache, light sensitivity, feeling off balance, nausea, and then not explained by other diagnosis. So that will become more, I think, fully enmeshed in concussion care over time. It was published just about less than a year ago. These are important for students and parents and coaches and administrators. There's a strong consensus that any of these necessitate removal from play. I'll let you read through those. Again, tonic posturing is classically the athlete does this and has a lot of muscle tone. It can be just for a few seconds and unfortunately can sometimes be missed. We also bring up red flags. If I'm seeing someone the day of a concussion, if I don't see any reasons to send them to the emergency department that day, I'll inform the student and the parents that any of these 3 should prompt an emergency department visit. These can be a sign of a higher level brain injury. Concussion is synonymous with mild traumatic brain injury, whereas we also have moderate and severe traumatic brain injury. So let's talk a bit about what we as teammates and adults can do. What can you do? How can you help? So what can a coach or parent or administrator do? There's 2 great tools. One is called the CRT6. The other is the CDC, for Centers for Disease Control Concussion Toolkit. These are available in app form. You can get a PDF and keep it on your phone. And we use the term sideline. I know that doesn't necessarily apply to every sport. It could be the dugout, the pitch side, the court side, the track side, the mat side. I'm sure I'm missing some, but just anybody that's on the, either coaching or observing should be aware of some of these basic resources that are available. These are both listed on the Utah High School Athletics Association website as well. They have a concussion care document that lists both of these. This is a picture of the CRT6, and I don't intend for anybody to read this. I know it's small, but it's pretty simple. And in this case, the red flags are more broad than the ones I've listed because it's designed to not miss anything. And so there's quite a few things on that list that would prompt someone to go to an emergency department if we don't have a medical provider present. Medical provider includes a physician. It includes an athletic trainer, and we have athletic trainers staffing all the high schools, although the athletic trainer obviously can't be at the JV football game and the volleyball game and the cheer practice at the same time, so it can be challenging. Okay, so in the days following the injury, what can we do to support a teammate? Show support, but don't overwhelm the teammate. And so in the first 48 hours, we don't want to have 40 people going by their house and talking and watching TV together. That's kind of a rest and recover time. But after 48 hours, yeah, it's good to get that student athlete out of the house and out doing things and having some social interaction. I talk about not creating a timeline recovery expectation, but the importance of creating an expectation of recovery, if that makes sense. And the former can put pressure on a teammate. The latter can be, really helpful, if that makes sense. Yeah, and we'll come back to this 48-hour window a little bit more in the next few slides. It's interesting. There was an NFL study, National Football League study, in the early from the late 90s to the early 2000s. And the conclusion from that study, looking at a lot of athletes, was it takes a week to get better from a concussion. Almost everybody was better for the next game. Big study with college athletes from 2013 to 2022. No, that's not the case. It's 2 weeks, 2 to 3 weeks before somebody's ready to get back to playing contact sport. The best study in youth athletes shows that the mean days until return to sport was 19.8, so about 20 days. So helping to reset the expectations as a community and as a team can really be helpful. Part of that timing is we generally wait till someone is symptom-free before progressing through this multi-day return to sport protocol. And so it takes some time. I'm going to just touch briefly on what happens with a medical evaluation. So on the sideline, whether it's an athletic trainer or a physician, there are specific things that we go over. These Maddox questions have been around for decades, and researchers still like them. I joke that if anybody in here gets a concussion, don't cheat by knowing these inside tricks. But the Maddox questions are: what venue are we at? What half is it? Or if it's hockey, what period are we in? If it's not a sport divided into halves, who scored most recently? And that doesn't apply to every single sport. Once again, if it's wrestling or something like that, but just these 5 questions can be adjusted as needed for sport. Who was our opponent the previous game or match or contest, and who won that previous game or match or contest? So those are those 5 questions, and anyone should be able to answer those. Maybe they can get 1 point off, but if they can't answer any, that's very telling for a concussion. We'll do a balance, vision, and exertional challenge if we think they may be able to be fit to return to sport. In the medical office, there's additional paperwork. So there's a sideline assessment and an office assessment. All these forms are from something called the Concussion in Sport Group, CISG, which is an international group of researchers. They publish updated criteria about every 5 years and name them after the city where they convened. And right now we're dealing with the Amsterdam guidelines, but it's in the Vienna guidelines, the Prague guidelines, and we just every 5 years get an update on latest research and recommendations for care. Interestingly, we look at vital signs. There's something called autonomic dysfunction. Concussion can cause your blood pressure to be too high or too low, or your pulse to be usually too fast, and that can make it harder to get back to sport. Just that brain cardiovascular interface can be something to look at. We always look at 4 symptom domains. Physical, that's one we all think of: headache, nausea, balance, light sensitivity. Cognitive, am I feeling foggy with my thinking? Is it hard to get back to my math class? Sleep, am I sleeping too much? Am I tired but I can't fall asleep? And then the last one is what we call affective or mental health. Again, a fairly common symptom category with concussion. There are some specific physical exam tests we do, and targeted treatment recommendations. It's interesting when you look at the national landscape. Some states are very vigilant about having any youth concussion victim see a physician before they're cleared back to sport. Others don't have that requirement. I was in Colorado for many years, and in Colorado that is the case. You have to see a physician or a doctor, a nurse practitioner, or PA before you can return to sport. In Utah, it can be an athletic trainer. That can obviously get a little nuanced. And my recommendation for this is have a good relationship as a doctor with the athletic trainers with whom I work, and for the athletic trainers have a good relationship with the doctors with whom they work, and then we work together to provide the best care we can for the patient, rather than having them feel competitive or, well, whose lane is this in? I cover Cedar Valley High School. That's my assigned high school. It's out on the west side of Saratoga Springs. The athletic trainer there's great, and we text and talk all the time, and doing that I think leads to the best outcomes for patients. Again, I'll emphasize concussion is treatable, and that's what we tell the patients the first time they come in. If we're giving you recommendations for home vision and balance drills and talking to you about your sleep specifically, those are your treatments. So use those as best you can. Let's just talk briefly about recovery. I'm going to go over a couple cases. These are actually cases I've seen in the last about 2 or 3 months. So this is a 15-year-old gentleman, freshman basketball game, going for a ball, loose ball, and collided and hit heads with an opponent. I didn't see him till about 2 weeks after his injury, and there's lots of reasons for that, but that's when I first saw him. We have a symptom score sheet that goes over those 4 categories: physical, cognitive, sleep, and the mental health. And there's 22 items with a total of 0 to 6. We use 0 to 6 in concussion instead of 0 to 10 for some reason. But his initial score was 78, with, again, a max of 132. So that's a really high symptom score. I saw him a few weeks ago. His symptom score was at 82. He was not improving. He was not attending school. The first time I saw him, he was doing this with the lights, slow responses, wouldn't really look at me, just looked at the ground. Yeah, this case unfortunately ended up with me recommending that he get emergent mental health care. He had some significant mental health challenges without a previous mental health diagnosis. I'm seeing him again next week. We're still working through it. The next case, 15-year-old female playing on a club ultimate frisbee team. She came in to see me about a broken finger, and I was looking through her medical chart, and I was like, boy, she was seen in the emergency room a week ago and had a concussion. And the family didn't even bring that up. And I just said, oh, I saw you were seen for a concussion a week ago. And they're like, yeah, she's fine. She actually had loss of consciousness, which the case I just talked through didn't have, but had her fill out a symptom score sheet, all zeros, exam normal. So, these are interesting and nuanced in terms of kind of the initial injury and then what we see. I at least talked through the education of things to watch for and doing what we call graded return to play before getting back to ultimate frisbee, which is not a collision sport, but is a contact sport. And we break sports down into non-contact, contact, collision. And anytime there's, soccer is a very collision sport, basketball, collision sport, tennis, things like that are non-collision sports. So first 48 hours. We used to talk about something called cocoon therapy, which was put them in a dark room and leave them there till they're feeling about better. That was, 20 years ago, not that long ago. We don't do that anymore. It's important to rest. It's important to avoid screens, but we basically tell people for 48 hours, do what you feel you can do. I have 2 slides on this because it's so important. So there's some debate about going back to school the day after a concussion if somebody's feeling pretty good. My Dr. Jackson recommendation is to not go to school for the first, at least day of and day after a concussion. Try some homework at home if you're feeling well, but let's do what we call a graded return. Limit screens, no formal sports. Try some homework. Go out and go for a walk. So that's where we talk about this exercise as medicine. And yeah, get out and go for a walk right away if you feel that would help de-stress and help kind of stretch out your legs. Often in concussion, there's one physical problem that's keeping someone from getting better. It may be that the neck pain is causing headaches, and once we treat the neck pain, things get better. It may be that the vision is off, and once we do some vision rehab or in rare cases, glasses or formal vision therapy where they go and see a sports optometrist, things get better. Often people have a hard time with loud noises and bright lights, and so it's okay to wear sunglasses and headphones for the initial period. Over time, people have to get used to those things again, so then we start saying, well, let's start doing more light and noise exposure just so you can get used to it. It's this, what we call graded return. So there's 3 components, school, sports, and screens. And we talk through just gradually getting back to all of those and that we should be doing those in kind of in parallel. We shouldn't be having somebody doing their formal return to football, but they haven't been back to school yet. No, we need to be back at school. We shouldn't be having somebody gaming on the computer, but they're not able to do their homework yet. They do this all a little bit at a time and move through it together. What happens if we don't follow this protocol? What happens if someone doesn't seek care? Just a higher likelihood of the symptoms coming back. There's an inherently longer recovery. Some interesting research shows that if you delay 1 day coming in to get seen for your concussion, it can take 3 to 5 days to get better. So it's kind of this cumulative effect if you don't seek care or get care or follow treatment early. There's more risks of mental health challenge if you don't follow these care protocols that the experts have developed. Risk of repeat concussion injury and risk of musculoskeletal injury. This is interesting stuff that I'm running out of time to explain, but several research studies showed that for an athlete that's had a concussion, let's say it's a basketball player in December has a concussion, they're unfortunately at higher risk for an ankle sprain or an ACL injury through the rest of that season. Why that is, we're still learning to understand. It doesn't mean that they shouldn't play sport, but just being aware of that and giving the best care we can for the concussion. So let's go over these take-home points again. Exercise is key for treatment. Getting people out walking day of or day after concussion during that first 48 hours. Some of the great research just in the last 5 years, a lot of this is out of the University of Buffalo back in New York, but a couple of researchers said that we're going to just see what happens if we try and have people that are still symptomatic from concussion do exercise. And they developed a treadmill test and did a lot of research looking at these youth athletes and college athletes doing exercise. Even if it triggers some symptoms, exercise can be helpful, and that's nuanced. But meaning, let's say your headache is moderate. You go out for a walk and, boy, my headache feels a little worse, but come back, headache's back to the baseline or actually gets better through the day. Exercise helps. Mental health symptoms, not being afraid to ask about those, not being afraid to address those is one of the keys. And then just with this recovery optimization, the idea that educating an athlete on what a concussion is, what they can do to recover. My goal is that a patient needs to have an initial same-day evaluation, whether that's with an athletic trainer or in a medical office. They shouldn't wait days to get in to get seen. And then with the athletic trainers, working with 2 universities and the high school with whom I work, the idea is if, in some cases, an athletic trainer can do a very good job caring for a concussion. But I talk about that if by 72 hours they're not symptom-free, I would like to see them just to add some of these treatments that we can put in place through our concussion clinic. I'll turn it over for questions. Are we good on time, Caleb? We're doing?
Yep.
Okay, so we have 15 minutes for questions, and happy to entertain any questions. Or yes?
Are there any studies that they've done on the amount of, because it seems like there's different varying severities, right, of these concussions, and there have even been times when I've hit my head before, and I wonder if I got minorly concussed from that.
Sure.
Is that a thing to get a subclinical concussion? Is that a real thing?
Yeah, that's a great question. And again, when I was a resident, so I did med school, and then you do a residency. I did a family medicine residency before my sports med fellowship. I remember working in our pediatric clinic, and we talked about the Cantu scale, and it was mild, moderate, or severe, and there were these criteria to meet the different levels of concussion. The research shows it's really hard to grade concussion. What could look like a really bad hit may recover quickly. What could look like a minor head impact may have real challenges with recovery. So there are no longer mild, moderate, severe concussions. Either you have a concussion or you don't. And kind of going back to these grading scales, is there a story? Is there one sign? Are there 2 symptoms? And if you meet those, then you have a concussion. But if you don't, you don't. And so I tend to tell people it's either a yes or no. It's not a maybe or mild or minor. We just have to, and especially with youth sport, I like to say we can watch it for a few hours, but within 12 hours we need to make a decision, because either we're going to school the next day or we're not. We're playing sport again or we're not. So I'll admit it's nuanced maybe in the first couple hours in some cases, and I'll often, if I see somebody at a Friday night football game for high school, I'll call the family or talk with the athletic trainer, and by Saturday morning we need to make a decision on whether it's a concussion or not. So, yeah, you in the front or in the middle there.
So you said that there can be major hits that don't hurt people that much or minor hits that do. Is there any indication of why one is more damaging than the other?
Yeah, great question as well. One of our sayings in concussion research is it's not so much the hit that causes the concussion, it's the brain that was concussed. And so we think everyone may have a different threshold for sustaining a concussion injury. If you've had a concussion at the start of a season, just like I talked about with musculoskeletal injury, you're more prone to get a concussion through that season, even if you get proper care and we follow the protocols. Are you 2% more likely, or are you 20% more likely? We don't really know, but we educate people on that. But it's something, our brains are all different, and so some brains are more prone than others to having a concussion period and having a speedy or slower recovery. We are continuing to research the specifics of the impact, and rotational impact may cause more concussion than a direct kind of axial or direct load impact concussion. Yeah, go ahead.
I was just curious to know what you kind of tell you are over Cedar Valley High School.
Yeah.
I'm just curious to know what you versus a concussion versus maybe a more severe TBI that might have symptoms like a subdural hemorrhage that might present maybe a week or two later.
Sure.
What are you telling your athletic trainers to look for that could be that threshold to be like, you should go get looked at medical attention? Besides that, that was a big hit.
Yeah. In rare cases, the injury itself will prompt an ER eval. For example, I work at the ski clinic in the winter as well, and if we have somebody that has a cracked helmet and I was going, crazy fast down a steep run, even if on exam I'm saying, well, I don't see anything worrisome, we'll still send them to the emergency room because of the helmet injury and the story. And there's all kinds of protocols in medicine to help make those decisions based on research. With athletic trainers, they're really sharp with this. And going back to those 3 red flags, those will cover the concerns almost every time. And so severe headache, repeated vomiting. The third one I admit is a little bit generic. It's neurologic dysfunction, and it can be anything from a seizure to losing vision in an eye to having a left arm not working. But any of those, even if they start to develop, that's going to the emergency department. The nice thing with high school sport and youth sport, some think concussion gets too much attention and has too much emphasis. Others argue not enough. But any state has a very kind of scripted and set in stone protocol. The Utah High School Athletic Association's a 6-page document. I pulled it up to make sure I was remembering it for this presentation, and it's quite by the book in terms of who needs to go to the emergency department, what resources do we need to use, what are our return protocols. Yeah, Dr. Seeley.
Yeah, can you talk more about the interaction between mental health challenges and concussion? I'd be curious to hear more about that.
Sure.
I'd add on what specific symptoms are you seeing more of one or another?
Yeah, on our we have these questionnaires, symptom score sheets. And so when I see somebody in clinic, we kind of fill out this form, and this is what I was talking about, the 4 categories: physical, thinking, sleep, emotional. If you want to grab one of these at the end, you're welcome to. The emotional symptoms are irritability, sadness, nervousness, feeling more emotional. So they're kind of general, and when we're trying to capture, instead of saying, do you have severe depression, do you have severe anxiety, we're saying, do you have any of these symptoms at all? And people that have a prior history of depression or anxiety are more likely to have that flare with concussion injury, but more often than not, it's someone who has no prior diagnosed mental health condition who develops some of those symptoms. And if people are being honest, most of them will have at least a little bit of emotional, what we call lability, or up and down after an injury. More commonly, it's depression. That's by far the most common one we see. It's maybe more irritability than anxiety, but usually it's a depression issue. And we treat it just like you would if you had depression for other reasons. And so in some cases, we'll start medication, usually not at the first visit. Usually it'll be 2 or 3 weeks in most cases before, but we may start a medication like you'd use for depression without having had it triggered by a concussion. We'll often do counseling with mental health staff, either with most universities have attached mental health staff, and they will be familiar with, okay, this is a depression triggered by concussion, or with a counselor in the community, and then just being willing to talk it through at each visit. That one case I mentioned with the adolescent basketball player, that was a hard case for me, a hard case for the family. The mom was, saying, I'm concerned, and we started talking, and he said, Mom, could you step out? And that's when he said to me, I'm thinking of hurting myself. And we just had him go to the emergency department. We've continued to follow him, and why that was triggered, it's because any part of that brain can be affected: the vision centers, the emotional centers, the cognitive and thought processing centers. So.
Another follow-up question. Obviously, this would be out of my league. I would never have to deal with this, but like when you start a medication because something's caused by a concussion, can you expect to be on that for the minimum 6 months?
Yeah, great question. Not always. We will. There's kind of a couple different avenues down which we can go with this, and there's one medicine that we use fairly often in concussion that's kind of an old-fashioned antidepressant, but we use it a lot in concussion because it helps with sleep and mood, and we're kind of killing 2 birds with 1 stone. And in that case, we'll use it for weeks, typically anywhere from 2 to 8 weeks. And then if that's not working, or we're a month out, things are not going well with the mental health side of things, that's where we may start a medication. And yes, it's probably maybe 3 months with concussion, but often we'll say, this was bad enough that I think it'd be better to keep you on this med for 6 to 12 months. That's not common, but it's we certainly see it. So, yeah. Yes, in the back.
Do you see gender differences at all with concussions, or like younger male or female?
Yeah. Okay. Another very debated point, and a lot of the research in the past suggested that women were more prone to men than concussion, or younger, female youth more so than male youth. That hasn't really panned out in the most recent research. It seems like there's a fairly equitable distribution of concussion amongst the gender, between the genders. The youth are more prone to concussion than adults, just smaller necks, bigger heads. So usually the forces at youth sport is not as intense as the forces in adult sport, but the data suggests that youth in sport are more prone to concussion. So, yeah. Go ahead.
Go ahead. Well, just with that, if youth are more prone to concussions, is there any indication of like long-term issues or mental problems or stuff for youth who have had concussions in the past, even if they were asymptomatic after the concussion and go back to sports?
The best answer to your question is we need more studies. The study that in which I was involved at the Air Force Academy was it was a 30 university study, and we started it in 2013. It's still going on, and we're hoping to get that answer with this study, at least for college-aged individuals, because it's really hard to do a study that lasts for decades. But we're basically touching base with these individuals. It was about, I think, 50,000 study participants with 6,000 concussions, so it's a really good data set. And hopefully in 20 years we'll know more about college-age concussion. We need to do that study with youth. We don't have clear evidence that concussion causes long-term problem. You probably all have, if you've heard of the movie Concussion, or you hear about the news with the NFL, chronic traumatic encephalopathy. At a certain point, if you've had long enough head impact, we do think there are long-term health issues leading to earlier dementia, and it's called chronic traumatic encephalopathy. It's just hard to find the threshold at which that happens. It's interesting. It's football linemen that tend to be most prone to this. You think of quarterbacks and wide receivers that kind of have these highlight reel hard hits, but the linemen are hitting their heads every play. And so there's something called head impact exposure and cumulative head impact. And so even if somebody's not getting a concussion every time they're playing their sport, just that idea of hitting my head over and over for years and years at a time, that's when we think there may be some long-term issues. Yeah.
One of your slides mentioned not to use ibuprofen, but acetaminophen instead. Why
Yeah.
is that?
Thanks for asking that question. And I know with the slides, sometimes I rush through things and don't clarify each bullet point. This is a theoretical risk, but ibuprofen is a mild anticoagulant or blood thinner. And so the idea is if somebody has an injury, the blood vessels in the brain are somewhat fragile, we avoid NSAIDs, ibuprofen, the most common one, in the small chance that it could trigger some brain bleeding. It's almost more hypothetical than something we see commonly, but it's still at least right now, something that we do. Acetaminophen can help with headache, but it won't cause any change in your tendency to bleed. So, yeah. Yes?
Have there been any studies with like prevention using hydration or diet changes?
There have been studies. I honestly don't think we've seen anything, and I'm hedging because I'm not sure if I'm remembering things correctly, but nothing. Obviously, better if you play in good health and you're less prone to get injured, it's probably an extrapolated link, if that makes sense. One thing I get questions about is this: what supplements can be helpful, and I'm certainly not endorsing anyone's supplement. These are on our Intermountain Health sheet, and but I just put them there because I do get questions about that. So, but much more important than these is just the basics of care that we've described. So, yes.
For several years, there were lots of guys in college and NFL wearing like those little bands.
Yeah, the Q collars. Yeah.
Research around that.
Yeah, those are really interesting to me. When I first heard about those, it just sounded so bizarre. I don't know if anybody knows the details of where this idea came from, but when you look at bighorn sheep and that kind of animal, how they butt heads for male dominance in the mating season, those animals have kind of a structure in their blood vessels that kind of protects the carotid artery when they hit their heads, and that's where these were developed, was off of that idea. I don't discourage people to use them. I don't think the research is there yet to say, yeah, these are a definite game changer, or they make a difference. But if someone wants to use it, great. So, yeah.
As far as like mental health standpoint, are you aware of research as far as best therapeutic approaches, whether it's like trauma-based approach or like cognitive behavioral therapy?
Yeah, just the standards. Cognitive behavioral therapy is where we usually start. Depends a little on if someone has a prior mental health history, but if it's, I never had any issues, I've had a concussion, I'm a month out and I'm feeling really depressed, then it's cognitive behavioral therapy. And, you know, it depends a lot on the age of the patient and the parents in terms of when we start meds. And I will bring it up at maybe 1 to 2 weeks, especially if things are really bad. I'll encourage it at 3 to 4 weeks if things aren't getting better. That's my practice, just so you have a little bit of a perspective there. But it's very much a shared decision-making model with the parents, usually if we're talking about youth sport, when a youth isn't at age to decide on their own, although we obviously want their buy-in if we're going to do it. So.
Connected with that, you said that sometimes these mental health issues can continue for months and years at a time. Is that considered a symptom for the concussion so they can't go back to the sports?
Yeah, another great question. No, and the research suggests the brain physiology is better by 28 days, even in cases that are slow to recover. After that time, we start talking about something used to be called post-concussion syndrome. Now we tend to call it persisting symptoms after concussion. Just like these other thresholds we've talked about in terms of musculoskeletal injury or injury for repeat concussion, we think, boy, all of us will get a headache if we're at a rock concert for long enough and, you know, we don't get any sleep. It may be that concussion, hey, your physiology is better, but your threshold for getting a concussion has just been a little bit lowered. And so, yeah, or your threshold for getting mental health symptoms is lowered. So at a certain point, especially with mental health symptoms, we may encourage return to play because it's really helpful for that athlete to get back to their team and what they like to do. That's also another nuanced issue. Headache, we're a little more cautious to return someone with headaches. There's rare cases where, boy, we think you're better. We've done all this assessment. You're more prone to getting headaches now, but we are going to allow you to return to sport. That's usually months down the road with a headache as a symptom. But mental health symptoms, we may return them if everything else is better and they're still dealing with that, with the thought that the physiology is better, but we've got this lowered threshold for having that symptom. So, Dr. Seeley.
Can I ask you another question? I know we're close on time.
Yeah.
This is potentially a sticky question, but I'm curious to know your thoughts based on what you know about concussion, generally about American football, and about youth participating
Sure.
in American football, and maybe talk to like differences in ages.
Yeah.
It's a really general question. I'd love to hear your philosophy.
Can I piggyback with that one as well? Because I was going to ask something similar. Because like
Yeah.
I'm in soccer, and so they're coming up with like rules at younger ages that you can't even head the ball.
Yeah.
Right. So I would assume it's kind of along those lines, like age appropriate.
Sure.
Like participation in youth sports in general.
Yeah. Yeah, it's interesting. It's coming back to this idea of what do we as a community and a culture want to do. Youth hockey is a great example. Youth hockey's had a lot more research on head injury, and for whatever reason, that community, those parents, those coaches, those researchers have been more aggressive at looking into this. And so we eliminated checking up to a certain age. We penalized back checking, significantly. I know football requires mouthguard too, but we've done research on mouthguards. It's something about just protecting a little bit of the jarring injury. Mouthguards seem to help. So yeah, I think with youth football, the research will suggest, I think, that we may want to push contact further, to later maybe mid to late adolescence. But that I love football. I love watching football, so I get it as a parent or coach or even spectator that we love this sport, and it's always kind of that challenging cultural what do we do? Is somebody more at risk for getting injured in college if they didn't start hitting until age 14 or 16? These are tough questions. So I'll share really well. Actually, we're out of time. I'll share it some other time when we're eating lunch. This is just a funny story from my life. So when I was at the Air Force Academy working with Dr. Darren Campbell, he's actually, we have a few of us that were Air Force that now work with Intermountain Health, but he went back to Washington, D.C. to meet with very important people in the military about the boxing program at the Air Force Academy. Every freshman is required to take a boxing course, eight lessons. Everybody has to box. And man, that generated, I have seen hundreds and hundreds of concussions, most of them courtesy of the Air Force Academy boxing program. And I was kind of fed up. Why are we doing this program? I just seen all these injuries. Why are we even doing this? And I was sure he was going to come back from meeting with these top military leaders and say, finally, we're not going to have boxing as a mandatory program anymore. He came back and said, well, guess what? I said, what? He said, not only are we continuing the program for males, it is now mandatory for females. So, and I get it. In the military, you have to learn grit, and that's how the military thinks you should learn it. I'm glad I didn't have to go through that curriculum. But you know, those are hard society questions, and it's you know, I don't have answers to that, but there's two sides of the coin, and I'm grateful we can do concussion research and have people that are interested in concussion injury. I appreciate you attending, and yeah, I hope, thanks to Dr. Seeley for putting on the conference.